Thank you so much, Shail, and it's indeed a honor to be a part of your course. And we have had this association for many years. These are just enumerating a few tips that I routinely follow in my practice. Do not use refractive astigmatism. All of us know is the anterior corneal astigmatism, which is most important. And just using refractive astigmatism may mislead you. This is just to show you the eye trace pictures. You can see this is from the internal optics, and this is from the cornea. The cornea is absolutely pristine, and this patient was wearing minus 1.5 diopters of power in the glasses right through the life. But the entire thing is coming from the lens, and in this case, when the cataract surgery is done, obviously this patient doesn't require a toric intraocular lens. On the other hand, you can have, these are practical examples. You can have a situation like this where the lenticular astigmatism and the anterior corneal astigmatism almost tend to neutralize each other. So once the lens is taken out, this corneal astigmatism is going to become manifest. So you definitely need to have a look at the spectacle power, the kind of cylinder that has been there, but do not be guided by that as far as the decision to implant a toric intraocular lens is concerned. It's essentially the anterior corneal curvature which is most important in determining this. Using the right instrument and the right formula is extremely important for biometry. And there are multiple formulae that are available to us, and every conference we keep discussing about what are the advances, the nuances, what is the differences. But as a guidance across all our centers, we use the Barrett suite of formula, which almost takes care of all our requirements. And our go-to formula as far as the evaluation of these patients is not the Barrett Universal 2 formula, but the Barrett toric calculator, and that's the primary formula in which we do all the measurements. It is simply because of this reason. As far as the suite of formula is concerned, it is available in the IOL master, various optical biometers. But just in case you do not have access to them, you can still benefit them from these formulae at the ASCRS and APSCRS websites, where it's available as a drop-down menu. You can see a situation like this against the rule astigmatism of just 0.6 diopters. Oftentimes I am asked that what is your cutoff as far as putting a toric intraocular lens is concerned. It is not just the magnitude of the cylinder that is important, it is also the axis which is extremely important. This is against the rule astigmatism. Just for a 0.6 diopters, it shows up a need for a T3 toric intraocular lens, and especially if it's a multifocal lens, it's definitely this needs to be taken care of. On the other hand, you look at the oblique astigmatism or with the rule astigmatism, this is a little more. Instead of 0.6, it's 0.68. But what the Barrett toric calculator is telling me is that this patient requires a non-toric lens. So that initially we are doing all our calculation by Barrett Universal 2, and then the patient will be counseled for a multifocal intraocular lens. When we look more deeply, we'll realize the patient actually requires a multifocal toric intraocular lens. So recounseling, the cost goes up, the patient is a little upset about it. Why was I not told this earlier? So that's the reason, as soon as the patient is decided for cataract surgery, even before he or she meets the counselor, we do this biometry and subsequently decide on this. I'm sure many of us are there. We have our own centers where some of them do not have an optical biometer, and this is the drop-down menu that's available in the APSCRS website right in the opening page, and you can have easy access to that even if you are not a member, and use the benefits of this. In case you are taking your measurements with immersion A scan and an auto keratometer or even a manual keratometer, the only thing you need to remember is that you need to use the acoustic A constant and not the optical A constant, in case there are two different A constant for that particular eye. Using that same, you can see over here, this is against the rule astigmatism of just 0.75 diopters, and what the formula tells me is that the patient needs a T3 toric intraocular lens. On the other hand, exactly the same amount of astigmatism, mind you, this is not on the optical biometer, but it is in the website, 0.75 diopters at 90 degrees, and what you need is a non-toric intraocular lens. So don't go with the cylinder in the spectacles. Don't go just by the magnitude of the astigmatism. Feed it into the formula and let that tell you whether the patient needs a toric or a non-toric intraocular lens. Obviously, this must have been emphasized even in this course, that correcting low astigmatism whenever you're resorting to any type of multifocals or EDOF lenses is extremely important. Let me illustrate this with you with an example. We had this patient of 0.87 diopters at 18 degrees, a reasonable amount of cylinder. That was a time when the trifocals were just coming into the market. We thought it's already an expensive lens. Making a trifocal toric is going to make it more expensive. Patient was planning to get both eyes operated. So he said, why just a diopter of astigmatism, less than a diopter? Let's go ahead and implant a trifocal, not a trifocal toric. And as you can see over here, got reasonably good near vision. Surprisingly, the distance vision was just 618. And you have this mixed astigmatism that is there, which was required for correcting the patient. It's not just the requirement for glasses, the quality of vision also deteriorates with this. But the patient was quite perceptive. We told him that wait for a period of 3 months. We ignored the cylinder, actually told him all the truth, and implanted this lens. But then you have this residual. We'll do a free laser vision correction at the end of 3 months and then take care of you. And while waiting there, because he was planning to get the surgery done in both eyes a week apart, he said, like, he believed in us. He said, let me go ahead and get the other eye operated. And almost the same amount of cylinder in the other eye, 0.86. And then what we did is to implant a toric trifocal lens in this case. And you can see the kind of impact that it has, that where the cylinder is also completely taken care of with a 6.6N6. Actually, the patient decided not to undergo the laser vision correction with the other eye, simply because with one eye corrected so optimally, other eye working well, almost to 90-95% for distance, and he decided that he could live with this. And again, as was emphasized already, with the rule and against the rule, astigmatism are completely two different animals. And you can see this. I'm emphasizing this because we need to understand this. The posterior corneal toricity, which is most often against the rule, needs to be considered. And you have a 0.98 diopters of against the rule astigmatism, and what's indicated a T4 intraocular lens. On the other hand, if you have a with the rule astigmatism, even a 0.75 is a non-toric intraocular lens that's indicated. So not just the power, but the axis of the astigmatism is also equally important. Another very important point you need to understand is that for a sub 2.4 millimeter temporal clear corneal incision, which is my normal incision, the SIA is just about, the surgically induced astigmatism is just about 0.1 diopters. I used the Hill calculator, and for a long time I used to believe that my incisions are creating an astigmatism of 0.44 diopters, and I used to incorporate that, and that may be one of the reasons for the suboptimal outcomes I used to have. But today we understand, with the seminal work done by Graham Barrett, Doc Cock, etc., that astigmatism just doesn't have a magnitude, but it also has a direction. And in the various points on the corneal surface, I'm not going to go into the details, they tend to neutralize each other, because of which what we are concerned about is the centroid value of the total astigmatism that the temporal clear corneal is creating. You can customize your centroid value, but since it is just in the range of about 0.1 diopters, it's really not worth wasting that time. And there are surgeons who do not just feed in SIA as 0 diopter. So that is the reason doing your incisions on axis has also been almost completely given up. And at least in my case, for a 2.4 millimeter incision, I do it always on a temporal 0 180 degrees axis. The only time I make a variation is if I'm implanting a phakic intraocular lens, where more often in the younger patients we have with the rule astigmatism, the patient has about 0.5, 0.6 diopters of astigmatism. I make a superior 3 millimeter incision, and a superior incisions always create a little more astigmatism than a temporal incision, and that takes care of a small amount of astigmatism. But this is not applicable to cataract surgery. And repeatable axis marking pre and intra-op is both necessary. I used to think this freehand marking is something which is not really scientific, should not be done. But I visited David Chang almost 7-8 years back in his surgery, and what I found was that before every patient, all he was asking them what to do was to look at his forehead and doing his freehand marking. Maybe he was an expert in doing that, but that's also one way of dealing with these patients. Otherwise, for a long time, we are using this bubble marker where it has to be absolutely perpendicular, parallel to the floor, and this bubble has to be in between these two lines. You get a mark on the 0, 180 and 90 degrees axis. Otherwise, I think if you do not have access to a digital marking device, then using a slit lamp before the pupil is dilated, creating a slit, cutting across the pupil, and I usually use a 26 gauge needle to mark, create a small subconjunctival hemorrhage over there, which will not disappear during the surgery. Of course, if you are doing a large volume of toric and intraocular lenses, which I believe all of us should be doing and addressing them, whether you're doing multifocals or not, having access to a digital marking device like the Varion or a Callisto is a great way to go. And this is intra-op alignment. Let me just show you a couple of videos, very short videos. And this is when I'm using viscoelastic. A gross alignment is done. That's the temporal clear corneal incision. Getting a good rhexis is extremely important so that you have a good overlap. And that's the intraocular lens that being injected in. And usually it's injected in such a manner that it's about falls shy of by about 10 to 15 degrees. These lenses can be rotated more comfortably only in the clockwise direction. And once you remove the viscoelastic quite completely, it's important that you remove the viscoelastic from the back of the lens also, and that's the reason I'm going behind. Also, do not overinflate these capsular bags, because if you have too much of fluid even behind, not just viscoelastic, there is a greater propensity for these lenses to rotate. And the final alignment is made, and even after the speculum is taken off, you have to make sure that the chamber is not shallow and the alignment is retained. That's extremely important. We did a study even comparing the manual alignment as well as the alignment using these digital devices. At least in our hands, we found that both of them worked equally well. So if you are reasonably experienced, it's not necessary that you need to have access to a digital alignment system. Nowadays, I'm doing more of this toric IOL hydroimplantation, and this is actually an Indian toric intraocular lens that is going in. And you can see it's a 2.8 millimeter incision. No viscoelastic is being used, and subsequently, maybe you might have noticed that I kept the IOP at 90 when I was injecting the lens because I wanted a well-inflated anterior chamber, and now I am exactly orienting the lens the way I want. The Varion overlay is there, but I need to switch the cameras to show that, and it will show up shortly. And this definitely reduces the amount of time taken for the entire surgery, and the need for removing the viscoelastics is also not there. And here I would like to mention a word about Indian and imported toric intraocular lenses. Obviously, the imported lenses are good. They have a lot of research has gone into it, and I am a high volume user of multifocals, torics, etc. But if in case you have a patient with a 1.5 diopters or 2 diopters astigmatism, he or she cannot afford a imported toric intraocular lens, we do not hesitate today to go ahead and implant Indian toric lenses. There are several manufacturers who come up with good quality lenses, and our cost of for the patient, the cost of an Indian toric intraocular lens and imported aspheric single piece lens is almost similar. So we'd rather give the advantage of the patient to neutralize the astigmatism rather than insisting just on imported lens being implanted. When there is a residual astigmatism that is there, these are the ways that by which you can deal with it, by IOL rotation, IOL exchange, piggyback intraocular lenses. Here again, the formula that we resort to, there is Barrett RX formula, and this works very well. Basically, this is a case where a 24 diopter T4 lens had been implanted, and the residual error, as you can see, is +1 diopter with 2.5 diopters. One factor that you do need to understand is rotation of these intraocular lenses will take care of the residual astigmatism only if the spherical equivalent of the residual error is almost zero. If supposing it was just a 1.5 diopters of cylinder, or if it was 1.5 diopters of sphere, rotation of this lens is not going to serve any purpose, simply because when you are rotating the lens, you are just redistributing the power and not introducing any extra power. But in this case, as you can see, the spherical equivalent of the residual error is nearly zero, so rotation will definitely help. And this tells me that rotating the lens by 6 degrees is going to take care of the astigmatism to a large extent, and that is exactly what was done. Just in case it's a very large amount of astigmatism, there's been some miscalculation of the patient has presented to you after a long time, then you can, IOL exchange can also be contemplated. The same formula can also give the benefit of that. If the capsule is completely fused down, still there is a certain amount of cylinder. Yesterday in our cataract panorama session also we showed this. Then it can be a piggyback lens also that can be introduced. This formula will tell you about that also. My final tips to maximize your outcomes as far as toric intraocular lens is concerned: take multiple measurements of the K reading. Consider but do not be guided by refractive cylinder. Check the ocular surface not just before the surgery but even before your biometry. The surgical induced astigmatism, the centroid value is just 0.1. The posterior corneal astigmatism is to be considered by the formula. Most modern formula do that. During the surgery itself, create a little longer incision so that a rectangular or a near square incision so that they seal up very well. Avoid over inflating because we do not want viscoelastic or fluid behind the lens. Most often the rotation occurs in the first 1 hour after toric intraocular lens implantation. That's the reason these patients alone, we always patch the eye, see them after a couple of hours, take off the patch and send them home. Nudge the intraocular lens onto the PC so that it is sitting on it. Make a slightly smaller rexis so that there's good overlap of the rexis uniformly in 360 degrees. Ensure that the position of the lens is maintained even once the speculum is off. And if at all there's a residual astigmatism, rotate about 2 weeks later. These are the two formula that are available to often use the Barrett RX formula. Thank you so much for your kind attention.
Thank you so much, sir, for that master class on toric IOLs. And I think the most important lesson that I learned from this talk was that calculate for all eyes, like sir mentioned, because it's sometimes in a busy OPD you tend to forget whether this is with the rule, against the rule. So don't rely on a value difference between K1 and K2. So don't have a cutoff that if K1, K2 is more than 1, you will consider. Calculate for each eyes, and like sir showed, in those cases you'll be surprised that so many of the cases where you had never thought of toric, they turn out to be T3, T4 rather than that. uh, yes, please go ahead.
So just one basic question. So just wanted to know, suppose if we are implanting a toric IOL and by chance or in the injector it rotates, like it front side is on the back side and back side is on the front. Is there any problem with that?
No, you should definitely, especially if it's a, single piece lens with a not a plate haptic design, you need to re-rotate them back because there is a these lenses, there is a toricity on the anterior surface, some of them, and so the multifocality is on the posterior surface. It's extremely important to reverse the lenses back. But if it is a plate haptic lens, if there which are planar lenses, then there is no need for rotation of this because they are bitoric. The toricity is distributed both on the anterior and posterior aspect. So if it's a in these left leading haptic should be having the mark, but just in case you are implanted it in a reverse manner, you need not reverse that. But all the routine lenses, the single piece lenses that we use with the haptics, they need to be reversed back into the right position.
Then IQ also we have to rotate.
Absolutely. IQ you will have to, it's only the Lisa toric maybe which you can leave it like that because it's a plate haptic lens.
Also, the lenses have posterior angulation. So that lens is actually like this. If you tilt it, you might also have a refractive surprise because the lens will sit more towards the cornea.
Okay, thank you very much to the audience for staying for the course, and thank you to the faculty for being part of this course. Thank you so much.